Ladies and gentlemen, thank you, Mr. Chair, for introduction. Thank you, Aris, for the invitation. You have always made it so perfect, superb scientific program, and great hospitality. I would really appreciate your attendance to this. I'm shifting completely from diagnosis now to fetal therapy. And my talk is about fetal lower urinary tract obstruction with some controversies that I'm going to emphasize regarding diagnosis and management. Let's first agree on the terminology, what we're talking about, and the importance of what I'm discussing. A lower urinary tract obstruction is a heterogeneous group of congenital anomaly that's presenting with a similar prenatal ultrasound finding. That's the megacystis, the dilated posterior urethra, the hydronephrosis, the oligohydramnios, and the associated renal dysplasia. And if you leave these fetuses untreated, there is a very high rate of perinatal morbidity and mortality due to the associated pulmonary hypoplasia and the early onset renal failure in infancy. When you talk about obstructive uropathy, the prevalence of the disease is anywhere from 2 to 3 per 1,000 births, 10,000 births, and it's the second most common underlying etiology leading to end-stage renal failure under the age of 16. At least this is based on a UK renal registry in 2015. And the perinatal mortality is up to 45% in untreated cases, with 30% developing end-stage renal failure requiring dialysis and transplantation by the age of 5 years. So let's start with the diagnosis. It seems to everybody, if I show you this picture, that even a resident in training can diagnose the typical appearance of an enlarged fetal bladder, what we call megacystis, and what's called a keyhole appearance of the bladder with this dilated urethra here. And then one would say this is an obstructed bladder and a fetal megacystis. But then again, if you look at this, you realize that there is plenty of amniotic fluid around this baby. And the first challenge really is to differentiate obstructive from non-obstructive etiologies on prenatal sonography. This is your first challenge, because both can have a similar ultrasound appearance. When you look at the underlying etiology, this is a classic slide, but when you look at the underlying etiology, we all know that posterior urethral valve is the etiology, and it's most common in male fetuses, compared to urethral atresia and stenosis that occurs in both male and female fetuses. And then there are things that like prune belly syndrome, which is a problem with a deficient abdominal wall musculature and an undescended testicle. But then you have other things coming in mind. So it's really this typical ultrasound finding of a dilated bladder, megacystis, and the dilated urethra, and even a bilateral hydronephrosis with dilated renal pelvis can be much more than LUTO. And there is this study that was published last year on a retrospective cases of 541 cases of megacystis from the Netherlands, where a final diagnosis was made in 418 cases. And you can see clearly here that in 53% this was an isolated LUTO. In 33% they had genetic chromosomal or structural anomalies like Turner, Vactor, cloacal malformation, all kind of trisomies. And 14% actually were normal or having an isolated urologic abnormality like a vesicourethral reflux. The importance of what I'm saying is that not every bladder obstruction really necessitates a treatment, and sometimes actually a treatment or an intervention in utero may not do much. Actually, it may be harmful. So a clinical score has been proposed recently, again, to improve the diagnostic accuracy of LUTO. And again, this is from the Netherlands. 312 fetuses over a 7 years period with the diagnosis of megacystis. The final diagnosis was achieved in 143. 124 had LUTO, and 19 were reclassified after birth as non-obstructive megacystis. And when you look at the different parameters looked at, from the fetal sex to the keyhole sign, echogenic kidney, oligohydramnios, all of them, bladder volume, bladder diameter, all of them showed that in case of LUTO, it was more common to have this compared to non-obstructive megacystis. But look at this. When you look at hydronephrosis, it was similar in both groups. So this means you can have a non-obstructive megacystis and have hydronephrosis, And this is again important to make the difference before you decide on further management or intervention in utero. And even when you look at what we all agree that these are probably one of the most common signs suggestive of obstructive megacystis, like oligohydramnios and anhydramnios, or a severe megacystis, you see the sensitivity individually of each marker is quite low. And that's why they suggested that if we put them together, and they proposed a clinical score that would improve your diagnosis of lower urinary tract obstruction compared to the classical triad of megacystis, the keyhole sign, and the hydronephrosis. And this score includes severe megacystis, the bilateral urethral diameters, the oligo or anhydramnios, and then everyone will get a score of 4, the presence of a male fetal sex and referral at less than 28 weeks. And if you have a score of more than 9.5, then this indicates luto. And they have shown that if you compare it to the classic trial, this luto clinical score improves your detection rate and makes it much more sensitive and specific. The other challenge is to decide on who is candidate for fetal therapy once you have this early megacystis. And this idea of trying to decide, is this really just an obstructive megacystis? Is this a complex? Is there a high chance of spontaneous resolution or urethral atresia? And again, looking at the same group, and they had this 142 megacystis, and they end up having 61 that had chromosomal abnormalities or anorectal malformation or multiple congenital anomalies, obviously not candidate for fetal therapy. They had 29 that had normal voiding at birth or isolated urologic anomaly like a vesicourethral reflux, and they were left only with luto in 52 cases where urethral atresia, posterior urethral valve, or urethral stenosis was the etiology. But what was interesting, they looked at 3 markers, and these markers were the nuchal translucency beyond 95th centile, the longitudinal bladder diameter, and one more thing. And just look at this here. All patients or fetuses who had a nuchal translucency or more than 95th centile, very few of them had luto. 6% had luto. And again, when you look at this algorithm or this decision tree analysis that they suggested, you can see out of those who had an NT more than 95th centile, 0% had isolated PUV. So this was a complex PUV that may include chromosomal abnormalities or other things. Of those who had a longitudinal bladder diameter more than 12 millimeters, 0% had an isolated PUV because most of them resolved in utero. And of those who had an umbilical cord cyst, associated umbilical cord cyst, 3% has an isolated PUV. In other words, we are trying to say that the best criteria for diagnosis of isolated posterior urethral valve that is eligible for early fetal therapy would be a nuchal translucency that's less than the 95th, because otherwise there is a high chance of a chromosomal abnormalities, a longitudinal bladder diameter that is more than 12 millimeters, because other than this, there is a high chance of spontaneous resolution in utero. And the third point is that there should be no ultrasound evidence of umbilical cord cyst, because as I showed you, when the umbilical cord cysts were present, the chance of having an isolated PUV was extremely low, around 3%. So again, when you see this image, which is even more challenging, and everybody can recognize it, we're talking in a first trimester, we're doing a lot of a first trimester scan. We've heard so many presentations talking about the value of a first trimester scan. So what would you counsel a patient like this who had this kind of image? Of course, it's very obvious. This is a megacystis, and then you put a color Doppler. You see the 2 renal artery that are engulfing the bladder. You confirm that this is the fetal bladder. But then again, how do you counsel about the possibility? What to do next if you have a 13 weeks or 12 or 14 weeks this dilated bladder? And again, this is the study that was published many years ago from the group of Nicolaides, the Fetal Medicine Foundation, where again they look at 3 parameters. If there is an abnormal karyotype, if there is a bladder length, that's 7 to 15 millimeters, the chance of having an abnormal karyotype is quite high, compared that if the bladder length is above 15. Then of those who had a bladder length between 7 to 15 millimeters, there is a very high chance, 90%, to resolve in utero. So you should not really be very much in a hurry for intervention or putting in shunt or doing a cystoscopy to ablate the valve. And the last one is when you have a bladder length more than 15 millimeter in the first trimester, there is almost 100% chance of having a bladder obstruction. So it's an easy diagnosis, but be careful before you start counseling parents and plan your perinatal management. Because it's much more than just saying, okay, in case if it's a boy, this is probably a posterior urethral valve. In case it's a girl, this is a urethral atresia. And look at, again, this image that I showed you earlier, and I just want to show you one more time. This is a dilated bladder with the typical appearance of the keyhole appearance. And you can see a lot of amniotic fluid around it. But then eventually this is a female fetus. And one of the things that has been described, I'm sure some of you, those who are probably more in the field, have seen this, but I can tell you this is something you don't want to miss. This is something you don't want to intervene on. And this is what's called this case where you have this typical appearance of the megacystis with the keyhole appearance. But again, you have a dilated fetal bowel here. And you have the dilated renal pelvis bilaterally, and this is the image at birth. And for those of you who have recognized this, you're right. This is something called a megacystis microcolon intestinal hypoperistalsis syndrome that has a very poor prognosis. It's almost 100% lethal with a very high neonatal mortality that you don't want to go into the fetal biochemistry of the urine. You don't want to do shunting or cystoscopy on somebody who has a difficult case that's not going to survive. And your first sign is going to be how to now, this is your third challenge, how you're going to do your prognostic evaluation and selection of fetal therapy. And the prognostic evaluation can be done at many levels. Obviously, we're in an ultrasound meeting, so the prognosis is going to be by ultrasonography as a screening tool. Then there is a value for the prognosis by fetal urine analysis. And then you select your suitable candidate for fetal therapy based on a combination of prognostic factor and the staging system. And I will discuss each one separately. Let's start by sonography. Everybody agrees that the most predictive ultrasonographic parameters at diagnosis for post-renal function were the renal cortical appearance, this is the presence of an echogenic kidney or echogenic renal parenchyma or cystic changes within the renal cortex, and of course the presence of oligohydramnios. But then if you look at this systematic review that looked at 13 studies and 215 women, they will confirm this to you and they will tell you this is the reality, you're absolutely right. This is how you should do. And many studies have correlated the appearance of the renal parenchyma with the end-stage renal failure. So you compared here those who had a very small renal parenchyma, a total renal parenchyma that's compared much significantly lower compared to those who do not have any end-stage renal disease. And this is how do you end up measuring the area of the hydronephrotic part and the echogenic kidneys. But then you have this paper that's, I couldn't even get the original, so it's still, it's published in the last month, but I had it from the author, and actually this was from Baylor, from Texas Children's Fetal Centers, looking at fetus with luteal and normal amniotic fluid in the second trimester. Because you would think if there is oligo and the renal or the kidneys are echogenic, then obviously there is a problem and the kidneys are not doing well and there is maybe an argument for intervention in utero. But what would you do if you have a luteal with a normal amniotic fluid in the second trimester? And basically what they look at these cases, and what's interesting is that even those who have a normal amniotic fluid in the second trimester of pregnancy, still 12% had neonatal need for dialysis among survivors and need for intubation or delivery in 28%, and even those who had positive pressure ventilation due to pulmonary hypoplasia. And of course, the diagnosis was the most common, posterior urethral valve. So you cannot just say that I would rely only on amniotic fluid. If it's low, if it's oligohydramnios, then for sure the kidneys are not doing well. And if it's maintained, then I have to reassure the patient or the couple and hold on intervention. Maybe this is not true because you can see that you can have normal amniotic fluid in the second trimester and still have patients that may require dialysis after birth in the neonatal period. The second thing that we looked at was the prognosis by fetal urine analysis. I still remember from the year of where I was doing the fellowship in the US, and at that time Mark Johnson was probably the man on all these kind of congenital lutos, and he has published a lot. And I remember telling us that the most important is not to rely on your first urine specimen, because the first urine specimen is going to reflect a long-term stasis in the fetal bladder. So this is not reflective of the renal function. And the second specimen, when you do it by vesicosynthesis after 48 hours, is just reflecting the urine that was collected in the upper urinary tract behind the obstruction. So again, it's not a good sample, and you should rely on the third urine sample. And I remember at that time, every fellow in the US in the maternal fetal medicine at that time was having in mind all these values, and we used to remember them. What's the cutoff for sodium, chloride, osmolarity, calcium, total protein, and beta-2 microglobulin. This was published in a very decent journal. This was something that everybody used to do. The third urine specimen, and these are the cutoffs that we want to agree on. Well, ladies and gentlemen, it seems that we are not going to tell you not to be disappointed, but a systematic review looking at 23 studies and 572 women showed that there was a massive heterogeneity between the study. All the studies were small cohort and retrospective study, and none of the fetal urine analyte investigated, we can say with certainty today, none of the fetal urine analyte investigated yielded sufficient clinically significant accuracy to predict postnatal renal function. Does this mean we have to quit on this? No, but it should not be your only parameter to decide on intervention. So then you decide now what to do with the intervention. Well, everything has been tried, but probably the most common would be the use of a thoracoamniotic shunt, especially after you do your first vesicosynthesis and then the bladder recollects and becomes distended again. And the shunt has been done, but this is not without problem. And then you can have fulguration by fetal cystoscopy of the actual obstruction. The problem with all these studies looking at intervention is that a lot of these studies were small, retrospective. There was only one randomized controlled trial. And yes, a lot of these studies would tell you that we improve perinatal survival, irrespective whether you do a shunting or cystoscopy, and the normal renal function at 6 months to 2 years. But what happened to these babies or to these neonates or to these infants later on beyond 2 years of age? This is the problem. This is when you achieve something at birth, but you end up delivering a child that has long-term renal insufficiency, and it's a significant one. So this is the shunting, and these are the complications with shunting. The shunt can be dislodged, can be occluded. Sometimes even you have oligohydramnios after shunting. So as much as it may sound to you easy to put a shunt, the complications are not few. And actually one has to be careful if one wants to take the risk. And again, we go back to identification of the cases. So this antenatal staging of luto, that again has been suggested that you can divide them in mild, moderate, and severe, is not always that easy, depending on bladder volume and the presence of oligohydramnios. Because you can call a mild luto with a normal amniotic fluid at 26 weeks, and I showed you earlier that some of these infants, 10 to 15%, even have required neonatal dialysis at birth. Obviously, the severe luto, we don't have any argument with this, and the moderate luto, we're going to consider intervention. And this classification has been correlated with perinatal mortality that goes from 8.6% in mild luto to 26% to 54% in severe luto, and with severe renal insufficiency reflected by a very low glomerular filtration rate from 11 to 31 to 44%. And this is the last thing that I'm going to talk about. This is a complicated, maybe look algorithm, but if you bear with me, I can walk you through this. So if you put the whole thing, what we have discussed together, we start with a suspected lower urinary tract obstruction with a screening ultrasound, of course, the typical dilated urethra, megacystis, and hydronephrosis. If you have oligohydramnios and hydramnios echogenic dysplastic kidney, especially before 24 weeks, you should really discuss with the patient the option of pregnancy termination, because this is a stage 4. If you have a normal amniotic fluid, and normal renal appearance, then of course we're talking about a mild luto here, or probably there is argument for monitoring every 1 to 2 weeks. And then if we're talking about oligohydramnios and echogenic kidney, the most important challenge, as we have discussed, make sure you discriminate whether this is obstructive or non-obstructive, based on the scoring system that I have talked about, based on your detailed assessment and your invasive test for chromosomal analysis, the fetal urine analysis, and the ultrasonography and the bladder filling. And if this is now, we're talking about the staging, we're talking about stage 2, where oligohydramnios, severe bilateral hydronephrosis, and a favorable fetal urine analysis. The role of fetal therapy at that time would be to prevent mortality and postnatal renal impairment. In case of stage 3, you will prevent mortality, but you may leave the child with postnatal renal impairment. And in case of stage 4, really there is no place in this case for any kind of intervention. And you better to have your hands off in this case in stage 3 and 4. So my conclusion, Mr. Chair, that despite 30 years of research, the fetal luto remains a difficult entity to treat. The ultrasonographic features and prospective fetal urine analysis may help in predicting the overall prognosis of congenital luto. The fetal vesicoamniotic shunting and cystoscopy with the fulguration of the obstruction are potential prenatal interventions. Retrospective and prospective cohort study and the relatively small, the only small randomized trial have demonstrated that this treatment may possibly improve perinatal survival, but despite that, the concern remains as to the high rates of renal impairments observed in pediatric survival, including the need for dialysis and severe renal insufficiency. And the clinical prospective scoring and staging system may improve the prenatal diagnostic criteria and case selection for fetal therapy. I would like to invite you all to our annual Congress that would be happening in Beirut in November 2018. This is one of the biggest Congress in the region. We have international speakers from all over the world, and I hope to see as many of you there. And I would like to show you the last slide from the campus of my university, where you have all the historical building with the Mediterranean Sea and the snow-capped mountain. So this, in a month like April or May like this, you can be skiing in the morning and going and swimming in the sea, in the Mediterranean Sea in the afternoon. Thank you.